Welcome, everyone, to the Pawsitive Veterinary Dentistry Podcast, the podcast dedicated to helping veterinary professionals elevate patient care through better dentistry, better diagnostics, and better decision-making. I'm your host, Benita Altier, licensed veterinary technician specialist in dentistry, and the founder of Pawsitive Dental Education. Today's episode is one I'm really excited about because it speaks directly to the heart of what we do every single day in practice: periodontal therapy and the critical role of the veterinary technician. This episode on the Frontlines of Periodontal Care, why veterinary technicians have a critical role, is one that will help you in your general day-to-day practice of veterinary dentistry. Periodontal disease is the most common disease we see in our canine and feline patients, and I did say the most common disease, and yet it is still one of the most underestimated, underdiscussed, and sometimes undertreated conditions in veterinary medicine. Veterinary technicians are often the first to recognize periodontal disease and the ones performing comprehensive periodontal therapy, and we can be the strongest advocates for our patients because we talk to clients so much and we really need to get them on board so they're a part of our team. We want to do this long before disease becomes severe because unfortunately we wind up treating a lot of patients that the disease has progressed so far that we can't actually be in tooth saving mode. We're actually having to advocate for tooth extractions, which isn't really the goal. We want to have animals keep their teeth their whole lives. So today I'm joined by Heidi Olivier, a certified veterinary technician and veterinary technician specialist in dentistry like myself. Her career spans general practice. She was in a veterinary university teaching hospital, specialty dentistry, and emergency. Her work has focused on dental diagnostics, periodontal therapy, oral pain management, and dental education. So like me, she's really passionate about educating professionals like you in a general practice setting so that we can all help more animals together. Heidi is a national speaker on veterinary dentistry. She is an executive board member on the Academy of Veterinary Dental Technicians, so I get to see her every month. She is an amazing secretary. I will definitely tell you, Heidi has been really organized. I'm so impressed how organized you are, Heidi. And she just took on a new role as Chief Education Officer at PerioVive. She is deeply dedicated to mentoring veterinary technicians, advancing dental standards, and empowering veterinary teams to advocate not only for their patients, but also for professional growth, fair compensation, and a healthy work-life balance, which I love that, Heidi. I definitely want to ask you more about that. I'm really excited to dive into our conversation today. So welcome, Heidi.
Thank you so much for having me. I'm excited.
So what we do on this podcast to have a little cliffhanger at the end and something fun at the beginning is the last guest leaves a question for the next guest, and you'll have one to give at the end for my following guest after you. And it's meant to be fun, but it's also helping us to learn more about each other and what we do in our real lives or veterinary dentistry. So what is the most unusual case or patient you have ever worked on?
Okay. I have a really good answer for this, I think.
Okay, perfect.
Mostly because it was my very last patient that I worked on in specialty practice. And his name is Quasimodo. Okay. And he is, just like the name, he has short spine syndrome. And so if you've ever seen, he's actually kind of famous, I guess you could say, for a dog. He has his own little following. If you follow him online, his name is Quasi the Great. You should check him out because he's adorable. He's like really good, like feel good material if you ever need to find something online to relax. But Quasi the Great has short spine syndrome. So he was born that way. And because of that, he is incredibly difficult to manage, not only in his periodontal disease and dental disease, as well as anesthesia. And so we got on kind of a routine with him where we saw him every 6 months, and it took a combination of a board-certified anesthesiologist, a board-certified dentist, a yes, and anesthesia, and myself every 6 months would see him because of his short spine syndrome. Sometimes he required endoscopic intubation because he couldn't move his neck, and so we had to. Over the years, we discovered the best way to intubate him, which was like in a lateral recumbency versus a sternal recumbency. We figured out what side was better over the other. And of course, he had different challenges with the anesthesia as well, his lung capacity and all that. And so I think that is just a really good example of how all of the departments can come together to work on a very special case and make sure, one, that he's safe, and two, that he keeps his teeth. Because another thing we were very scared of is because he couldn't really open his mouth very wide. So cleaning his teeth was very difficult. We had to contort into all different positions. Taking x-rays was very difficult. But we really didn't want to have to extract any teeth in the back of his mouth, because that would involve probably a very large extraoral surgery, like opening up his cheek. And so his owners, I give them a lot of credit, are so dedicated to his care. And really, we saw him every 6 months. And so that's one sad thing about leaving general practice, is that I won't be seeing Kwasi anymore, but I know he's still going to get the dental care he needs. I know he'll be there every 6 months.
Oh gosh, wow. Yeah, that's a case that sounds like it has so many complexities that it takes the whole team. So amazing. So he's doing okay now though, right? As far as you know?
Yeah, check him out online. He's wonderful. He's the best little guy.
He's got a following on his Instagram and TikTok.
He does. A pretty big one. Yeah, he's like the most famous patient we see or so. Which is silly to say, but it's kind of like a little celebrity that walked in the door every 6 months.
Oh, yeah. Oh, my goodness. That's really exciting. Well, we do sometimes see famous patients, or they become famous to us. So that's super cool. And yeah, be thinking about a question for the next guest. So my first question, we're going to talk about how periodontal disease has a start. And we want to really figure out how can we advocate for patients. So when we think about it being the most common disease we see in our patients, yet it's often not addressed until it's advanced, why do you think it's so important that we really start that conversation early on in a patient's life at a puppy or kitten visit?
Yeah, I think it's essential to start that conversation on day one. So, if you're in a general practice setting, when you see that puppy or kitten at 8 weeks, at 12 weeks, at 16 weeks, we just need to supply them with little nuggets of information. And I think it's important to set the standard in the beginning so that when you see them back at 1 year and you say, hey, it's time for your first dental cleaning, they're like, I've heard this before. You told me I was going to need to be back in a year to do this. And they hear it from you every single time they come to visit, usually regardless of any reason, right? I'm usually asking them what's going on with their mouth. Does that patient's breath smell? Do they have any concerns that way? Let's take a look in the mouth. Because then the unfortunate thing is, in my specialty practice, I saw the worst of the worst. And so we were often seeing 13, 14, 15-year-old dogs and cats that at that point needed full mouth extractions. And for a whole host of reasons. One is a blind neglect. Maybe they just didn't realize that dental care was important. And I think that has a lot to do with us as the veterinary professionals, is we need to keep that at the forefront in our daily conversation with them. And so the guilt that they would feel at the time that they saw me and their pet is in pain, they're suffering, maybe they have an abscess, maybe they have a pathologic jaw fracture, the guilt they feel is horrible, and it's something you have to walk them through. I'm sorry this happened, but you're here now and we're going to fix it. And so I think we can we can't always prevent that type of thing from happening, but if we start it on day one when we see them as puppies and kittens, again, the front line of periodontal disease is the technicians in the room every single time.
Yeah, I think that it's really important that we don't make them feel guilty. But they're so excited about those new puppy or kitten visits that they want to just be like a sponge. They want to take in all the information we're trying to give them. And if the receptionists, when they schedule the appointment with them, and also us as technicians in the room, and then the doctors talking to them, if we all have a touch point with the client, we can really make a difference, I think, in their understanding of how we all think this is really important. And the cool thing about periodontal disease, it's actually preventable, right?
Right.
And so when we're in the room and we're talking to the owners, I've definitely heard people say things that sort of backpedal really good recommendations. Sometimes we've said things like, well, I think it can wait, or it's not that bad yet. Mm-hmm. Why do you think that kind of language is so damaging to advocating for our patients? And what would you say to the client if they say, well, can't it just wait? Or I don't think it's that bad yet. If the client is saying that, how can we change the script a little bit just to make it so that the clients understand that this is going to be a part of their wellness care throughout their life?
Yeah, I think that sometimes we put our own fears and our own perceptions on what an owner is willing to do. As technicians, sometimes we're very cost focused, we're money conscious. And so sometimes it's very difficult to recommend a very expensive procedure because maybe you think they can't afford it. But I was continuously surprised in my experience by the people that went for the procedure and didn't go for the procedure. But it was my job, regardless of how much it costs, regardless of how sick the patient was, of their anesthetic concerns, to offer the gold standard of care and then alter based on their needs. And so I'm always going to offer you the gold star, and then we're going to discuss together what seems reasonable for you. Maybe you can't get your pet in every single year for a cleaning, but maybe we could talk about every other year or every third year. And we're going to talk about really good home care in between so that maybe we can stop the progression of periodontal disease. I think that sometimes we take a one size approach and it's not right for every single patient and every single owner and what they're capable of. And so I think having an honest conversation with them as far as, hey, it's not ideal that we can't get Fluffy in every single year for a cleaning, but I hear that maybe you can do it every second year, but here's what we can do in between those things. And so I think being honest with them and letting them know what could happen or what might happen, it may be, hey, we're going to expect some extractions next year, but if you're willing to accept that risk, if you're willing to provide some home care or be in contact with me, if you're seeing something that is concerning, I think it all just really boils down to good communication. Because I think if an owner feels heard, that's first and foremost, because they don't want to feel like you're just selling them something. They want to know why you're recommending it and the data, the science behind it, and ultimately they want to do right for their pet, right? They want what's best for their pet and they want them to be happy and comfortable. So if you come at it as an approach like that, I think it's much more palatable for owners.
Yeah, I think that's true. One thing that I would say is that when we think about talking to them, we want to come across as we are pet owners ourselves. Mm-hmm. And we can even share some stories or testimonials about how we've been able to incorporate home care in between the professional visits, because I think what overwhelms owners is thinking about having their pet go under anesthesia every year. But unfortunately, if we don't do home care and we don't do professional care, that's when the periodontal disease really takes hold. And once it does, we can't really go back to where it was before it happened. So like you said, we really just got to somehow figure out the right words to use to appeal to their logic, but also their heart, because they're very concerned about taking good care of their pet, but then they're also very concerned about the scary thing we know as death. And we think it's anesthesia, but it's really death. People are so afraid. And dentistry shouldn't be fear-inducing, we hope, right? But people might also have fear because they don't like going to the dentist, right?
Right. Yeah, exactly. I think it all boils down to just being empathetic with owners. Like that is something I've spent a lot of time in rooms with owners, and no matter what the problem was, if you can just boil it down to some empathy, like, hey, I can relate. I had an XYZ situation that happened similarly, and I'm going to help you through it. I think it's hard sometimes because sometimes when you've been in vet med long enough, you can sort of jump to being defensive if somebody doesn't want to do something or if they're kind of giving you pushback. But I think if we just boil it back down to, hey, this person's here and they're asking for help, and it's my job to figure out what kind of help to give them.
Yeah, I love that. So I feel veterinary technicians play a really huge role in recognizing periodontal disease before anesthesia even happens. So what should technicians be looking for during those conscious oral exams that may indicate periodontal disease is present or potentially progressing?
Well, the first thing I pay attention to is the smell. Sometimes even before you enter the room, sometimes you say, well, okay. And if you've done enough dentistry, if you've been around enough mouths, you know the smell of dental disease and you know if something nefarious is going on. There's a very particular smell to a very infected mouth. So that's the first thing I pay attention to is before we go in the room or once I'm in the room, how does the room smell? 2, I'm going to ask the owner what they feel is going on. And so we're going to ask some good questions to the owner. Secondly, I'm going to just look at that patient from across the room. Maybe they're drooling, maybe their eye is squinting, maybe they have nasal discharge, maybe they have a swelling, or maybe they have nothing going on at all. But if you're going to do a good conscious oral exam, you're going to palpate our structures, you're going to feel for swelling, you're going to feel for atrophy, you're going to feel for things like that. And then if your patient allows, if they have a good temperament, you're going to flip the lip and try to take a look inside. You're going to assess for, I think gingivitis is much more important to assess versus a calculus index. I know calculus can be very misleading sometimes. And sometimes we have really terrible calculus and sometimes we have no calculus at all. So I try to pay attention to if things are bleeding, if they're smelly, if they're red and inflamed, if there's bone loss. And then any sort of obvious pathology, if there's a tumor hanging out, if there's a fracture, if there's missing teeth or extra teeth, I try to get a really good visual of that in our limited, what do we have, 20 to 30 seconds?
Right, very limited.
Taking all of that in together to kind of give us the best clue we have going forward into our procedure, our anesthetized oral exam.
Okay. Yeah, I was teaching with a veterinary dentist recently, and she was telling the doctors, do not write calculus. I do not want you guys to even write calculus down in your medical record because it really doesn't have bearing on the outcome. So when we think about looking at that gingival health, I feel like that's one of the most important points that you made there. When we think about periodontal disease, even just defining that, when we think about staging periodontal disease, like what do you think about when it comes to the conscious oral exam and how you would potentially imagine what the stage of periodontal disease is? Because we clearly can't actually stage it until we have dental radiographs. So with the patient awake, is there anything that you have as a tip or trick to help the veterinarian or technician understand potentially what stage we're at?
Well, I always say we're like a little detective, right? We have to take all of our clues and do our best guess to what's going on until they're under anesthesia. So what does it smell like? What am I seeing? What's my past experience like? You know, I've seen patients like this before. We got really good in my specialty practice where we could look at something and say, this is probably 2 to 3 hours of extraction time. Or also on the other end of that, we would say, oh, this doesn't look so bad. Maybe it's just an hour of an extraction time. And then you get them under anesthesia and you're completely surprised because every single tooth in the mouth has resorption or something else going on under the gum line that you didn't anticipate. And so I think sometimes we can do everything right and still be completely surprised. And so that's to your point about calculus not being a real indicator of the stage of periodontal disease, because I have seen the most pristine mouths be atrocious under anesthesia, the worst pockets, the worst bone loss, things like that. So it can be very difficult, but I think it comes with time and experience mostly.
Yeah. Funny thing, teeth are like a box of chocolates. You don't know until you get to the inside.
That's true. That's true. And sometimes it's coconut flavored and
yeah, might not be your favorite flavor there for sure. So how, as a technician, do you feel like you can help communicate that properly and document that to the veterinarian so that we can schedule those patients properly and get them treated when they're under anesthesia? Is there any tips or tricks that you have in regards to how you would document that conscious oral exam to help us understand better how to actually place that patient in our schedule?
Sure. I think you, as a team, you should probably have a standardized way that you report things. I know in my practice, we had our standard SOPs for our oral exams. And so you're going to take note of the gingivitis. You're going to take note of the pathology. You're going to take note of what the owner says, very importantly, because if the owner's telling you like they're not eating, they're dropping food, that kind of stuff, that's going to be a clue that something else is going on. And then I think, too, we have to just assume that things are going to take longer than you think they are, and then just be happy when they're shorter. And so I don't know that you can ever just say, oh, this is a stage or a level 1 or a stage 1 dental procedure, because we just don't know until they're under anesthesia. So I don't know that I have like the magic bullet there for how to better communicate that, other than just one, having understanding between your team on what's acceptable in your medical record, and then having a really standardized way that you report it.
Yeah. I feel that if they have a full set of dental radiographs from last year, it's way easier to determine what we may be up against this year. Is that something that you guys would normally do? Is if they're
Yeah,
here, go back and review their images from last year
absolutely.
and their chart?
That's a really good point, is if they are repeat patients, which if you're in a general practice, you probably are getting those annual patients. This is a really good reason to do really accurate charting, right? So take a look at your chart from the previous year. Maybe you had on your canine teeth, you had some mid-level pocketing that you did some root planing on. And this year, you're like, ooh, okay, we might be in a position where those are going to be okay, or we're going to have to extract them. So it could go both ways. So I think that's a really, really good point, is looking at what was done last year, and that's going to clue you in. Maybe that patient had 25 extractions the year before, and they've been really diligent about home care. So maybe this year it's just a straightforward cleaning.
That would be nice. I love it when that happens.
Right.
And I feel that if we get them on that plan of doing this on some sort of routine basis
Mm-hmm.
and establish a baseline by taking full mouth dental x-rays earlier in their life to make sure that the roots formed normally, that we have normal root morphology, we have strong, healthy bone, let's keep it that way. But if we don't have
Right.
that information from them visiting us or even visiting another veterinarian where they've done that before, we just are really in that box of chocolates situation where we don't know what we're up against. And when we think about how much time it's going to take, I'm totally with you about just adding on more time for those patients when we don't have that prior information to look back on. So when we think about periodontal therapy, I feel that technicians have a really strong role to play. And I feel that this is where people go wrong in the veterinary profession. They just don't really think that there's an option to save teeth sometimes. And they don't really have the skills or the knowledge to actually do that properly. So we're going to talk now about when we have a patient under anesthesia, what exactly does it mean to do periodontal therapy? And how do technicians truly shine in this particular part of the dental procedure?
Sure. I think periodontal therapy doesn't have to be as scary as it sounds. I think, we put this label on it, and in my day-to-day life, I talk to general practitioners and technicians every single day, and words like root planing really scare them. But then I say, hey, but are you using an ultrasonic scaler? Do you know how to identify a curette? And they say yes. And they say yes. I say, do you use that under the gum line? Yes. I go, congratulations. You're probably doing some root planing. And I think it's just simplifying it. I think we tend to overcomplicate things. I think if you start with some really good CE or reading, that is going to be really important. Attending labs so that you can feel confident in your skills. And then also finding a mentor in your practice. There's usually at least one technician that's very into dentistry, or a doctor within the practice that's very good with dentistry, and seeking them out and saying, hey, I want to get better at my dentistry. How can I do, first and foremost, how can I as a technician do a really good oral exam, learn how to probe the teeth, learn how to assess furcations, mobility, and gingival recession, and learn what it means. Not just what it is, but learn what that means for the patient, learn what attachment loss means, learn to read an x-ray. And pretty soon you're going to get just as good or better at reading x-rays as your doctor is. And you're going to be like, that tooth probably needs to be extracted, doesn't it, doctor? And so I think it's really just comes down to educating yourself and then getting the confidence and the tools and support to help you succeed.
Exactly. When we talk about hand instruments specifically, because that is one of the places where a lot of hospitals may have some hand instruments, but they don't necessarily know how to identify what is a curette and what is a hand scaler, and even understanding how to adapt those instruments properly to the tooth surface to clean it, as well as understanding how important it is that those instruments are kept sharp. Do
Mm-hmm.
you have any specific hints or tips for practices in regards to how to build the infrastructure so that we do have the instrumentation that we need to save some teeth?
Yeah, I think we should treat our dental instruments the same that we treat our regular surgery instruments. I know you and I do a lot of training, and we'll go in and we see the best of the best. And sometimes you just get a drawer of like instruments that are banging around each other. And that's okay. It's probably just because nobody's told them they probably shouldn't be doing that. And so I think first and foremost is taking a really good inventory of what you have. If you have one curette and you've had it for 30 years, maybe it's time to get a new one. Open up the catalog, call your sales rep. And a lot of times there are really good kits that you can get that just have there's 3 or 4 curettes, there's a hand scaler, there's a mirror, there's a probe, and then you order 2 of them so you can autoclave them in between. It's worth the investment. And then it's worth, a lot of times what I do is, again, because we tend to overcomplicate things, is I'll say, take your inventory, take your instrument out. A lot of times there's a number on that instrument. Just Google it. Mm-hmm. Say, what is a Columbia this number? And then the internet can tell you, oh, you use it this way.
Okay, Heidi. So one thing that I think our viewers, our listeners would really like to know more about is root planing. And I know root planing sounds like, as you mentioned, a scary subject to some people because it sounds really complicated. But can you define the different types of root planing for the listeners and really explain a little bit better about technique in regards to root planing and how that would apply to saving teeth?
Sure, yeah. So there are 2 different types of root planing. You either have a closed root planing or an open root planing. And really the only difference there is whether you are lifting a flap. So open root planing is a surgical technique, and I guess in my opinion should be done under the hands of a veterinarian as they are trained in surgical principles. And so to back up, closed root planing is something certainly that a technician could do or a veterinarian. Closed root planing would be in your shallower pockets, typically 5 millimeters or less, because usually our instruments can't reach beyond 5 millimeters. And that's when you would be having to convert to an open root planing if you were looking at saving a tooth or potentially saving a tooth. And so in closed root planing, what you're going to do is you're going to clean the teeth as you normally would with your instruments, whether that's an ultrasonic scaler or what have you. And then you're going to pay close attention to that root surface. And so you're going to pick an instrument that fits the size and shape of the sulcus. And so you're going to take a look at your hand instruments, find a curette that can go under the gum line. And what you're going to do is you're just going to gently but firmly apply your curette to the cementum, that root surface, in an upward stroke. And so you're just going to clean that over and over again until your cementum is clean of all of the debris, necrotic tissue. That granulation tissue is really important for removing. We want to make sure that root surface is super, super clean. And then you're going to flip your curette over. I know it seems wrong, but that's what you're going to do. And you're going to do what's called subgingival curettage. This is a really important step in root planing in general, either closed or open. And that's where you're taking that cutting edge of the curette and you're just gently scraping the inside of that gingiva. And again, you're just removing that extra granulation tissue because what you want to be left with is 2 smooth surfaces that can sandwich together then and give you the best chance of closing down that pocket. Now would be a time where, if it's appropriate, you could add in your periosteutics. So whatever your periosteutic of choice is, if you're doing bone grafting or guided tissue regeneration, you could certainly consider that with an open root planing as well. Open root planing is the exact same process, but as I said, you're going to be lifting that flap or your doctor's going to be lifting that flap and then proceeding with that same process. And then, of course, suturing closed. I think open root planing is a little bit higher stakes because that is where you're treating a deeper pocket, right? And so that tooth is probably a little bit less likely to survive in the end anyway, but we're doing what we can.
It gets serious when we think about saving teeth that are more important, like a big major maxillary canine tooth. And a common tooth that we wind up having a situation like this would be on the palatal aspect of a maxillary canine tooth, right? Which is a very difficult place to clean because there's a bone wall of the maxillary palate there, as well as the tooth structure, which kind of makes it difficult to get down into that space to clean it properly. And as you mentioned, having that instrument adapted to that tooth root and making sure that we are actually seeing that there isn't any more debris coming out is super important. So I love how you defined the difference between what we can do with blindly going in there and cleaning that root surface with a curette versus what we can do that has to be done with a visual aspect. So like you mentioned, surgically, a doctor would create some sort of flap, maybe like an envelope flap versus something with a vertical releasing incision, which would be more invasive but potentially necessary in some situations, to visually inspect that tooth root and be able to assess that it is actually clean, because in order for us to save the tooth, we can't leave any biological yuck material down there, including on the inner lining of the soft tissue, which is when you said to flip the curette over and to do that subgingival curettage. So all of this is super important. Do you personally recommend, or do you usually do any kind of ultrasonic scaling after the root planing is done, or is that something that you would have done just before? And talk a little bit about how the ultrasonic tip plays into this as well when we talk about cleaning below the gum line.
Yeah, so ultrasonic scaling, I am typically doing that before using any of my hand instrumentation, kind of that initial cleaning, because you really want to get a secondary look down either with your air water syringe or after you've lifted the flap, and then you can take your hand instruments down there. As far as the tip, you do have to get to know your type of ultrasonic scaler that you have, and a lot of them require different tips to go subgingivally, or even a lesser power setting. So because that cementum is more porous and more sensitive. And so you want to make sure that you're using the appropriate tip, that it has the appropriate length, checking that a lot of those come with like little cards that you can check the length to make sure it's working properly. You want to make sure all of that is set up before, at the beginning of the day, before you're in and you're doing your procedure, to make sure that everything's functioning correctly and that you're using it in the appropriate space in the mouth.
Yeah, that's great. And I feel that the combination of power equipment and hand instrumentation really gives us the best outcome. I personally got in the habit of going back in after I did my closed root planing and putting my periodontally acceptable ultrasonic scaler tip on my scaler handle so that I could go down below the gum line again, because I feel like it rinses out the debris that we've dislodged with our hand instrumentation. So we may do that as the primary cleaning below the gum line, but then I personally like going back in. I think it's called periodontal debridement, using the ultrasonic scaler tip, that ultrasonic cavitational forces to help decrease the bacterial concentration below the gum line and ensure that hopefully we've made it a much more hospitable place for healing versus the proliferation of those bacterial populations that we're trying to get rid of. And you mentioned perioceuticals. So this is really important because there are different perioceuticals that have been on the market for different periods of time out there that people are more familiar with. If you don't do the root planing and you decide to put some sort of preparation on the tooth root, is that okay? Can you just put the stuff down there and call it good, or do you need to do that root planing?
Really good question. I think we're all looking for kind of that miracle, right? We just want something to work and we don't want to have to do much. And so
yeah, let's not work so hard. Let's just make it simple. Yeah, so what can we do to not work so hard?
And I think perioceutics are always going to work best in the face of really good periodontal treatment. And so cleaning that tooth root surface is that extra step, but we really need to do that first before we're just going to place a perioceutic down into the pocket or wherever you're placing it. And so doing your closed root planing, doing your open root planing, and then adding in the adjunct is only going to make your perioceutic work that much better, or work at all. Because if we don't remove that granulation tissue on both sides of the surface, we're really doing a disservice. You're probably not going to get as effective treatment or closure of the pocket in that situation.
And the goal is to hopefully allow periodontal ligament fibers to reattach bone to tooth cementum, right? So if we don't do the proper cleaning, that's not going to be possible, because you literally will have physical barrier to that process, which is calculus left on the root surface. I think there was a study done in the last 5 years or so that said comparatively, if you root planed properly versus root planing and putting something perioceutic wise below the gum line, that there may not be a huge difference, but if you don't root plane properly, we've completely lost the game of trying to save teeth, right? So I think that there definitely is more studies to be done, but it's a great case to be made that I always tell people you can take the perioceutic product, whatever that is, and either put it in a clean, prepared pocket which has been root planed properly and subdentivally curetaged, or you can just take it and go squirt it into the literal trash can. Because if you're putting it in a dirty place, you might as well just really take it over to the literal trash can and squirt it in there, because you're wasting your time and the client's money, right?
Yeah, exactly. We don't want to waste our money, and we don't want to waste the client's money, and we want a product that's going to work. So why not? We're just going to take that extra step, and so that everyone's a winner.
Yeah.
Including our patients, right? Yes. It's ultimately about the patients. We want
to ultimately about the patients.
Yeah.
Exactly. And thinking that through too, we want them to have success with this periodontal therapy, whether it might be just doing proper cleaning above and below the gum line, including the root plating closed or open, and making sure that we've smoothed out any rough surfaces so they're less plaque retentive through our polishing techniques and whatnot. When it comes to rechecking the patients after they've had some sort of periodontal therapy like this, what did you experience working in the practices that you've worked in regarding having patients coming back for follow-up visits, whether it's an awake visit where you're just talking to the client, maybe discussing home care, or if it's coming back for a repeated anesthetic procedure to assess the effectiveness of our treatment?
Sure. So lots of layers to that question. I think that if we're doing some sort of periodontal treatment, specifically if we're doing like open root planing, which requires a flap, right? We treat that the same way as an extraction as far as going home. So we're not going to want that patient or that owner to really disturb that area, disturb that site for at least 2 to 3 weeks for the healing period. And so applying something like an OraVet sealant can really help bridge that gap in between from procedure to rechecking, ideally in person, right, in that 2 to 3 week time frame. Once things are healed, then we can talk about providing some home care. Obviously, daily brushing is best if we can ever convince our owners to do that, or I find that a quick demonstration or just talking them through some behavior modifications with the owner is really valuable, spending some of that time with the owner in the room to talk about why brushing is best and how to set themselves up for success with brushing, I think is really important. And then we can talk about layering of some other home care things if they're up for it, if it's appropriate for that patient, dental diets, dental chews, consider water additives, things of that nature that can only help, right, and not hurt. And then as far as having them rechecked under anesthesia, I think what's really up to the practitioner. I think ideally they could come back in 6 months if money wasn't an issue or time wasn't an issue, right? If none of that mattered, we would have every single patient back under, I think, within 6 months. But I would say more realistically, most people are following up in that 9 to 12 month range. And that's okay too, because owners are just trying to do their best. And so if we can see them once a year, we're happy with that to check on the treatment that we've performed.
Yeah, that sounds realistic. And I think they always tell people to brush the teeth you want to keep and brush your teeth if you want friends.
Yeah.
But when it comes to brushing animals' teeth, that can be a really difficult thing. And we have to pick our patients wisely if we're going to do tooth saving type procedures. Number one, hopefully the owner can, if they're willing, teach themselves and teach the pet to accept something more invasive like toothbrushing. But as you mentioned, there are other things that could be utilized that are more hands-off activities. You have to feed your pets, so you might as well feed them some sort of diet that already has the mechanical removal of plaque kind of built into its nature, or potentially a chemical like hexametaphosphate or some sort of other way of reducing the plaque accumulation through enzymes and whatnot. Mm-hmm. Also thinking about chews and water additives and all the things that we could find on the VOHC website for these patients. I always like to have the client choose what they will do, and then we would set them up for success by getting them set up with those products. I also feel like it's a great idea to have them go ahead and buy the things that you want them to use, because if they've got a financial investment in these items, I feel like they're more likely to go ahead and use them, versus if we give them free things, they might just throw them in the drawer at home and kind of forget about brushing the teeth. But that second touch point that you mentioned, I felt was really important in our practice as well, to have them come back to assess healing, but to also have the opportunity to go over with them some of the home care things that they could do and show them on their pet how to do it, and have them show you so that they can start to work towards that ideal daily home care, toothbrushing, so that they set up a routine. And that patient might be an older patient that's never had their teeth brushed in all 10 years of their life, right? So this may not be successful for every pet out there, every pet parent. It just has to be something that as professionals we talk about, we recommend, and making sure we have that touch point with them, and then getting them back under anesthesia. There's some patients that are higher risk patients anesthetically, comorbidities or other situations, or the client may not have the funds to put them under anesthesia as frequently as would be ideal, but we have to meet them where they are. So hopefully we can reassess the situation and go back at it again and try to stabilize, because generally speaking, we can't make the bone grow back up to the height it once was. But if we can stabilize it and not let it get worse, hopefully get some reattachment of soft tissue, periodontal ligament fibers, as I mentioned, bone to cementum on the tooth root, maybe we can keep that big important tooth for a longer period of time. So along those lines, I know you just started working for a company that has a new product, and the product isn't new to the world, but it's something that is fairly new to veterinary medicine and veterinary dentistry. I know there's a lot of research behind it, but I would definitely love to hear more about it, because as we talked about adding some preparation to the tooth surface or the root surface or below the gum line, I think this could be a really big game changer for a lot of our patients, and something that's not difficult to do, and something that's really pretty cost effective in regards to the hopeful outcomes. So can you tell us, Heidi, a little bit more about PerioVive and hyaluronic acid and how that could be coming up in the future of veterinary dentistry?
Yeah, I'd love to. So yeah, now I work full time with PerioVive, which has been really fun. It's been really nice working for a company and for a product that you believe in.
Yeah.
So that always helps. I think I'm almost mad that we didn't have this product 10 years ago, because it's been around in human dentistry for quite a while, at least a decade. And so it's just now making its way over to the veterinary market. PerioVive was the first product that was brought over for hyaluronic acid, specifically for the oral cavity. And like you said, there is just tons and tons of research on why it works in a dentistry setting. There's something like 100+ studies that were done in humans, really in every single aspect you could think of, in extraction sites, in implant surgery, in wisdom teeth removal, in oral inflammatory conditions. It's been studied and been shown to be effective, including there's been about 10+ studies in animals and 5 or so in dogs. And so we have all of this data out there on how it works. And so I think that's something that specifically makes PerioVive unique, is that it is so data driven. And so it's not just us telling you that the product works, we have all of this information to support that. And so hyaluronic acid, I think, is to me more than just a periosteutic, meaning you can use it more than just the pocket. I think it's certainly beneficial in the pocket. In the face of root planing, you're going to help regenerate your tissues. It's osteoinductive, so it's going to help bring back new healthy cementum. It's going to help bring back or reform your periodontal ligament, your gingival tissues. And so it's going to provide a lot of regeneration that way. But you can also use it in your extraction sites. So post-extraction sites, it's going to help bring back more healthy mineralized bone. It's going to help speed the healing process. And then I also think a really understated benefit of hyaluronic acid is that it does provide some local pain control. And so how that works, it's not an analgesic by nature, but it has anti-inflammatory properties. So reducing that overall inflammation, getting them back to function quicker. But what else it does is it helps coat those pain receptors down within the alveolus, similar to how a nerve block would plug those receptors, and then so therefore blocking some of that transmission of pain to your patient. So you're waking up more comfortably. You can also use it in furcation defects. We're seeing some really cool x-rays now. Now that PerioVive has been around long enough, this is the really cool part. We're seeing this was the treatment a year ago where we did root planing and PerioVive placement, and this is now a year later, and look at these x-rays. And it's really, really cool to see that like just live in person. And then lastly, because there's more, you can use it for inflammation, such as just treating your run-of-the-mill gingivitis, but also helping out our inflammatory conditions. So feline stomatitis, whether you have a refractory stomatitis case or at the time of treatment, it's really, really beneficial for healing and inflammation. Or I'm thinking our C-cus dogs, this could be very, very beneficial. or our feline juvenile gingivitis. I think this product could be really, really cool, adding it into that home care regimen to help reduce the inflammation in those cats specifically. So yeah, it's a really exciting product, and I get really excited talking about it just because I think there's so many good benefits, and I think we're going to help so many patients, especially those inflammatory patients that we weren't able to otherwise help.
Wow, that sounds really great. And it's like, okay, is this the next miracle cure? Is it really all that, right? Mm-hmm. But what I would definitely want to know more about, and I think you alluded to it, is this something that could be done on an awake patient, or is this something that's just done under anesthesia?
Sure. I think both are true. If you're doing closed root planing, open root planing, if you are treating a furcation defect or an extraction site, that patient should absolutely be asleep. But there are scenarios where you might want to apply it topically. And certainly in refractory stomatitis cats, you can coach owners to apply it topically when they have flares. Same with your other inflammatory conditions. Or if you're just treating a routine gingivitis, we could teach owners to apply it topically as well to the gingiva. I will say we are working on a home care product. And so it's in the works. So I can't really give you all the details, maybe just like a teaser, but we're working on a home care product that's going to be essentially a daily dose of hyaluronic acid where patients can then just drink up that hyaluronic acid, because we understand the limitations of having owners apply it topically. And so it's going to be more of an ease of use. I think for our inflammatory patients that really need that daily dose, it's going to be really beneficial for them, or just your run-of-the-mill use for gingivitis. We know that gingivitis leads to inflammation, which leads to periodontitis, which leads to eventual tooth loss. And anything we can do to slow down inflammation in our patient's mouth, I think is highly beneficial. So again, I'm mad that I didn't have it 10 years ago and I couldn't start it on my own dogs, but yeah, I think it's going to be something that might be a game changer. So that's your little teaser that something is coming.
Well, that's exciting. So this was news to me. So
yeah,
that sounds really great. Is there any kind of negative to this product that you know of? Anything that would be a contraindication, or when a veterinary professional would potentially think twice about using this product in a patient?
Good question. So hyaluronic acid is endogenous to the body. It's endogenous to all of our patients. We're all mammals, right? And it's not like we're introducing something foreign into the body. We're not seeing adverse drug reactions that way. It's a very, very safe and biocompatible product to use in our patients. So we don't have to worry there. I will say the only contraindication is that we don't recommend using it in neoplastic conditions. And so if you have a tumor that you're performing surgery on and you're removing that with margins, certainly if you've removed it, you've got margins, you can put it into your flap repair. But the reason is the data is mixed on whether hyaluronic acid could help or harm a tumor. And so until we have definitive information on that, we're not going to recommend using it in neoplastic conditions or something that you might suspect is neoplastic where you're unsure. And so if you're doing a biopsy and you're not sure if this could potentially be neoplastic, we wouldn't recommend using it in that situation.
Okay, that makes sense. Yeah, so limited application in that particular situation, but very broad application, it sounds like, overall. So that's really amazing. Is this something that's very expensive for the client or for the veterinary team to purchase?
That's a really good question. And no, the answer is no. It's actually pretty cheap, which I find as a technician, something like that goes in the pro column, right? It's so $65 for a syringe. And in that syringe, you'll get that 1 cc. But it's not just a one-time use product. It's good for 2 weeks once you open it. And on average, you can really use that between 4 to 6 patients because a little goes a long way. Typically 0.1 mil or less per site. So whether you're treating an extraction site or you're treating a pocket, a little really goes a long way. You don't need a lot to have that regeneration or that healing effect. So yeah, you're getting costs to the clinic per patient is pretty minimal.
That's great, because a lot of times we're hesitant to try products, especially if we think it's going to be cost prohibitive, making the procedure so much more expensive that the client won't consent to that treatment. And then also the fact that this can be used on multiple patients without problems, that's super helpful, because a lot of times if we have a open it today, use it all today type of situation, we are hesitant to embrace something like that because we know we may not be able to use that all in the period of time in which the product would still be a viable product. So Good news. That sounds really exciting. And I know that we can link some information on the show notes for some of that research, because as veterinary professionals, we definitely want to make sure to do our homework before we just adopt a new product into our procedures. So I want to make sure the listeners have access to the research materials. And I know right now that you're doing some in-clinic virtual webinars about this product too, so that if they are interested, we could get some information from you as well regarding how they can sign up for something like that and potentially get some free product.
Buy 4, get 1 free. Yep.
Buy 4, get 1 free.
Yep.
Yes. Okay. So that they can start without having a big financial output in trying to see how this product seems to work for their patients. So thank you so much for explaining that. I feel like that's going to be a game changer for a lot of patients, and something else that we can focus on when it comes to saving teeth, because saving teeth is a worthy pursuit. We definitely want patients to keep all their teeth, but especially those 10 essential bigger teeth that we like to work harder on if we can, because they do have more function and usually longer, more sturdy root surfaces, so that we can work on saving them. And I'm glad to hear too that potentially could help with some fricational areas, because we don't want fricational bone loss to equal toothanasia, the end of life for that tooth. Ideally, if we could do something to help with that. So is there anything that you can think of that you'd like to add to the conversation regarding periodontal therapy or some of these instrumentation things or perioceutics?
Sure. I think maybe we could just leave it at treating periodontal disease doesn't have to be scary. I know it's overwhelming because there's just so much information. There's books as big as my head on periodontal disease, which if you're not a dentistry nerd like you and myself, that can seem very overwhelming. But it is something that we need to learn, I think, in general practice. Most of our patients have some level of periodontal disease. So it is our obligation to at least understand the process and how it happens and how it works, and then learn how to treat it, right? And so it doesn't mean we have to be experts. It doesn't mean we have to offer every single treatment that's available to us. But it does mean that we have to do a good job cleaning their teeth, do a good job making recommendations, and then perhaps offering something additional if we'd like to. So I think it's a theme. It all lies in our education, right? And so when we know better, we do better. And I think that it's worth seeking out that extra CE just to learn how we can better help our patients.
Wonderful. That sounds really perfect. And if we have a patient that we feel needs that type of care and it's over our comfort zone or over the level of expertise that we have, it's never wrong to refer a patient if you think a veterinary dentist would be more suited to doing the advanced periodontal therapy, the surgeries, the guided tissue regeneration, or bone inductive materials and things like that. But as you mentioned, most of this is definitely something we see in a general practice setting all the time. And a lot of these techniques are underutilized, definitely doable, and something that we can embrace and start doing in our general practice settings. So I hope this podcast today has really inspired you all to want to learn more about saving teeth, not just about extractions. Thank you so much for that, Heidi. So before we leave the episode today, you get to leave a question for my next guest. So what is your question that you would like to leave for the next guest on the Pawsitive Veterinary Dentistry Podcast?
Okay, I know all of us listening are probably doing a lot of dentistry, and for me, the weirdest thing I've ever found while cleaning a patient's mouth, or also grossest, was actually a human toenail stuck in the furcation of an upper fourth premolar, which was pretty devastating to learn that when you pulled it out that it was a human toenail.
That was disgusting.
That was like a really good show and tell day at my work.
Yeah, hopefully, well, I don't know if you wanted a picture of that. You probably can't unsee that. So
there's a picture somewhere that exists. I'd have to go deep into the drive to find that.
No worries. We won't need to go for that. I don't need to put that up on the show.
No, nobody wants to.
Probably not.
So I want to know, what is the weirdest or grossest or strangest thing you've ever found while either cleaning a patient's mouth or working in your patient's mouth?
Perfect. That'll be a great question. I love it. Thank you all for listening in or watching on my YouTube channel, Pawsitive Veterinary Dentistry Podcast. And thank you, Heidi, so much for being my guest. I really appreciate it. You are very knowledgeable, and I definitely love the experience that you bring to the table here, and also the information about PerioVibe. So we're going to learn more about PerioVibe moving forward. And for the listeners, thank you so much. Listen wherever you listen to podcasts. Follow me on Instagram, LinkedIn, YouTube, TikTok, and do positive dentistry. And I will see you next time on the Pawsitive Veterinary Dentistry Podcast.